Okay, so what we're going to look at now is gallbladder 21 or needling the upper trapezius. So this is the point that gets referenced as the point that causes the majority of pneumothoraces, but if we get this in the right location, we should be superior and lateral to the first rib and therefore outside of the apex of the lungs. So the first thing we want to do is identify the acromion. So if you, again, find the spine of the scapula, track across, find the acromion, and if we come over to T1, gallbladder 21 is located midway between these two, and it should be over here, should be lateral to the medial border of the scapula. What we should also do is when we're palpating this tissue, rather than just pressing in anywhere to find anywhere that's tender, because the tendency then is actually to move medial to this point and find this point here the most tender by pressing down. The reason this occurs is you're pressing down on the first rib, so you're compressing the muscle against the bone, but what you've also got going on is you've got levator scap coming through here, so you've got a number of muscles that you're pressing on. You can press it against the bone, you confirm that it's the most tender, but you're actually in danger of creating a false positive with this. The way to palpate trapezius to find the tender fibres is actually to palpate it from above in this position and just roll your finger gently across the fibres here. So we're looking for a more superficial location. So this should be roughly halfway between the acromion and T1. So we find that location, palpate it just to confirm that's the tightness. Then we're going to be needling this. What we want to do is to identify the underlying anatomy. So find the spine of the scapula again, which is here. Find the medial border. Okay. The relevance of the medial border to this point is not its location, it's the safety factor relative to the ribs. The first rib ends roughly at the medial border of the scapula. So if we find the first rib, which will be the highest piece of bone lateral to the cervical and thoracic spine here, so we find this bone here, we move lateral, what should happen is it should disappear by the time we get to here. The reason being is the first rib is here, but at the front, if you watch my fingers, the first rib is right down here. So the rib, as it moves laterally, then has to move anteriorly and inferiorly very quickly to get beneath the sternoclavicular joint. So as a result, there's no first rib out here. So once it starts to move laterally and disappear, we're in the tissue lateral and superior to the first rib, which puts us in an area of safety. So just to recap that, as we move across, it should start to disappear under here. Now, one of the things you'll find is you're looking for the first rib and you'll say, well, I can't find the first rib. Well, that's great because it's disappearing. You want it to be in that position. So when I come to palpate this to needle, what I'm going to do is I'm going to bring my hand over the tissue and palpate the tissue here. And rather than just pick the tissue up, and in this instance, this tissue is quite tight. So when I go to pick it up, what happens is the skin and the adipose tissue just collect in my hand and I lose the muscle. So if I draw this up and needle it, I'm now just needling adipose tissue and not muscular tissue. So what I actually want to do is get hold of the muscular tissue. But if I get hold of the muscular tissue, it's going to be very painful for him because his upper traps are tight. That's why we're needling them. So what we need to do is just very gently, rather than grab it like that, is just approximate the tissue between my fingers. Once I've done that, I can then mobilise that tissue to identify that there's no ribs there, there's no clavicle, I'm lateral to the first rib, I'm above the second rib, so when I insert a needle into there and track it towards my finger, keeping my finger there for the proprioception of the needle, I know where the ribs are, I know where the tip of the needle is, so I'm at no risk of getting a pneumothorax. What I can also do with this hand is as I lay over his shoulder, I can feel cervical spine, thoracic spine, I can feel the scapula, spine of the scapula. These fingers here, I can pop around here, I can feel the apex of his lungs where it's going to be, I can feel his first rib, I can feel his clavicle, I can hold the tissue, I can insert the needle. This hand is telling me everything that's going on with that anatomy and I know I'm safe. Rather than that sort of technique. If you just pick the tissue up and you're in the wrong location, so if I go here, I pick this up and I'm needling the bulk of the tissue, look what happens when I let go of my finger. See how low down I am. That's the first rib. This is the first intercostal space. This is probably the second intercostal space. Needling here with that technique is a very good way to get pneumothorax. It's fine to needle more medial than gallbladder 21, but you will need to adapt your technique to the shape of the ribs. More time you spend with your hand on the thoracic cage and the ribs and palpating, the better you'll understand where you need to be and the safer you'll be.